Hello, I'm Dr. De Leon. I'm a physical medicine and rehabilitation specialist. I started my career as a combat medic. Eventually became an emergency medical technician in New York City in the 911 system. After becoming a doctor, I became EMT course director at Fort Campbell. And I've been teaching medics, medical students, primary care residents, nurse practitioners, physician residents for years. So I'm making these series of videos to help give you good clinical information to use out in the primary care areas, out in the field or in the clinic. All right. We'll be doing a series of neuro right now, and we're going to do spinal cord injury. All right, so let's understand the spine. The spine is a series of stacked bones. We break the spine into segments. The neck we call cervical. There are 7 of those. Then we have 12 with our 12 ribs. Thoracic. When we run out of ribs, we have the lower back lumbar. 5 of those, and then continues into your pelvis and the sacral bone. Each of the bone is basically the same, and I brought in a lumbar model. You have a solid cylinder of bone with an arch of bone on the back side. All right, so I'll come up a little closer. If you line up all the arches, you create a tunnel for your spinal cord to pass through. Between the solid cylinders of bones, you have your jelly donut disc, and each of the arches themselves projects up and down, touches the eye above and below. So at each level, you have 3 joints, your 2 facet joints, and your jelly donut disc. Between the arches inside, you have space where the nerves come out, and each of the arches projects backwards and outwards for different muscular attachments. All right, so the difference between the lumbar spine, cervical spine is basically, they're smaller, they're not carrying as much weight. The angle of these joints, all right, are at a different angle. They're more up and down rather than sideways like this. And these sideways sections are more box-like than plate-like. As you move into the chest, they become more plate-like, and you add in the ribs. All right, so, and occasionally you may see in cervical spine x-rays, somebody say uncovertebral joint. It's basically on the side here where this bone just comes down a little longer, and it actually forms a little joint there. Clinically irrelevant in terms of considering the spine. Now, we break the spine into columns. So just like a heart attack, you need 2 out of 3 to declare a heart attack. A good story, an EKG or enzymes, you get 2 out of 3, we call you're having a heart attack, we give you treatment. In case of the spine, for trauma or degenerative disease, we talk about columns of the spine, and you need 2 out of 3 to be unstable. So if I take a bandsaw and cut right at the base of the pedicles, and I pull off the arches en masse, that is the posterior column. If I take a bandsaw and cut right down the center of the bone here, then we have the anterior column and the middle column. All right, you need to work in 2 out of 3. The things that are not represented here, besides the muscles and ligaments, is going down the front, you have a duct tape, anterior longitudinal ligament. You have a solid cylinder of bone, super glued to the disc, super glued to the bone. On the inside of the arch here, on the back side of the solid cylinder, you have another piece of duct tape going down the back, the posterior longitudinal ligament. On the arches themselves, if you go down the back of the arches, a 3rd piece of duct tape, that's the ligamentum flavum. All right, so that is the spinal anatomy. All right, and again, you have to be broken in 2 out of 3. So if we think about that, we'll back up. You take our little old lady, as she gets osteoporosis with age, she gets anterior wedge fractures, and next thing you know, she's got a little hunchback because all of those wedges then stack up and start curving her spine. Some people also have pars defects. So the arches themselves are cracked, all right, and that can create instability on the posterior arch, and if the other 2 segments, the anterior middle segments, hold, you have a stable spine. If they don't, your spine can become unstable, and you may need surgery to stabilize it. Those, in terms of the pars defects, the anterior wedge, those are more chronic conditions. Those are things that You have time to sort out, the surgeons will deal with it. You're not in the acute emergent setting, which is what we're more concerned about here. All right, so in the acute emergent setting, someone has trauma, car accident, rollover, fall from height, then you can have that spinal cord injury. It's the bones are trying to protect. So when you don't know, you just gotta, we have a patient down, we don't have x-ray vision, we go ahead and put the collar on, put them on a spine board, immobilize the spine, protect them from further injury as we evac them up. All right, there's a nexus criteria about how to clear a spine clinically, right, done basically at the provider level in the primary care or ER, whatever, that can be done without imaging. And that's a separate lecture. We're assuming that this mechanism of injury, this person is worried that they could have or do have a spinal cord injury. So when we think about spinal cord injuries, we classify them by completeness. So to start with, we have an Asia scale. It starts at Asia A. When we think of Asia A, we think of a meat cleaver. You take a meat cleaver, you chop the spine in two, and everything above the meat cleaver is fine. Everything below the meat cleaver is disconnected, gone, doesn't work. And when we're testing it, like we talked before, nerves, you have motor sensory, so we're checking motor sensory, and everything is out below the level of injury. So this is a complete injury. All right? That is the only complete injury. And then everything below that, we have an A or alpha. We're going across Charlie, Delta, and Echo. Everything below this is incomplete. So how do we define complete versus incomplete? Your spinal cord ends about here. It stopped growing when you were 7 or something. You kept growing and you stretched out, and all those nerves then stretched out and became spaghetti strings down here as they came out and left. The last thing to come off the spinal cord is destined for your bottom, for your butthole. All right, so that's how we check it. If the spinal cord injury is complete, that means below the level of injury, nothing is getting through. And so if anything is getting through to the butthole, to the rectum, then it's incomplete. So then all of these other ones are incomplete. So when you're checking it, right, you're doing your trauma assessment, you're getting trauma naked, right, you're looking for all your HABCs, hemorrhage, airway, breathing, circulation, stability. You're going to do that sweep. You're going to be checking the rectum for blood. You're going to be checking the penis and the anus for blood coming out. All right. You can also, in a conscious patient, all right, check sensation. It doesn't matter if they can tell whether it's a sharp or dull sensation, just that they feel anything. Now, we're not talking about finger all the way up and that deep pressure into the rectum, because that's going to get there via a different nerve pathway, but right around the butthole, the skin around the butthole. Can they feel anything? If they can feel anything, it's an incomplete injury. If they can't, then it's a complete injury. All right? And so, all right, sorry for the technical difficulties. Apparently I had to clear out my phone and get some storage off of it. And use geriatric equipment, because I keep something until it actually doesn't work anymore. All right, so we were talking about Asia B. All right, so an incomplete injury. So that means the last thing off the spinal cord, all right, is going to your rectum. So any sensation, perirectal sensation, will be then an incomplete injury. So all of these can feel around the butthole, even if they can't tell sharp dull, they can feel something on the external rectum. A complete means they cannot. And so we define these by then the motor. So you're checking sensory motor, sensory motor. So below the level of injury, nothing moves. So below it, everything is paralyzed. Then we go weak movement. Strong movement. And normal exam. History of spinal cord injury. So, motor recension, motor recension. So how do we check those things? Well, on the sensory side, just like we do with Chinese pulse motor sensory, right? You have sharp versus dull. So you can get a paper clip, bend out the edge, you poke it, it's kind of sharp. You use the rounded end, it's kind of dull. All right? So you can go down both sides of the body, right, from the neck down, going down and just keep poking. And when can they not tell the difference between sharp and dull? And when do they lose any sensation? You can't tell they're being touched. So as you go down the front, just go down the front of the chest, on either side, you can have a different spinal cord level from the right and left, right, from the same injury. Right, because injuries basically aren't meat cleavers. They're more crush injuries, torque injuries, things like that. So these wires can be broken, damaged, bruised at different levels. All right, so as you go down, pulse motor sensory. All right, you can go down the torso as you go down the front of the leg. All right, and then come up the back to the butthole. As you go down the arm, you're going down the top of the arm to the thumb, to the pinky, and on the inside. All right, you don't have to do every little millimeter, but if you get some gross spots, then you can say, well, okay, he can tell here, normal, I can't feel that. Okay, let me focus between these two levels. When does it stop? Okay, it stops right around here. All right, well, belly button's T10, that's T7, so that's about T8 level. All right, you don't have to know that, just know below the rib cage on the right about an inch, that's when sensation stops. Between the rib cage and that spot, it's abnormal. All right, that's what you're marking. You don't have to be too exact, just be in the ballpark. So again, neck, shoulder, upper arm, thumb, middle fingers, pinky side of the hand, pinky side of the arm, come down the chest, down the front to the leg, top of the foot, bottom of the foot, back of the leg, a couple of spots, going to then toward the rectum. Can they tell sharp, dull? All right, and that's going to give us the sensory side and another sensory side. Why is this so critically important? All right, as we continue with the motor, the big reason we're worried about learning all of this is for the surgeons. Because if you do a good exam at the point of injury and in transit, and then they examine them 3 hours later, you know, when they finally get to a trauma center, right, in the military system, it can take hours to get there, or even a day or two as they go through different echelons of care, all right? The neurosurgeon re-examines them and they can say, well, at this level, their exam showed this, and now I'm seeing this. This is getting better. Maybe I don't need to rush to surgery, or it's getting worse. So that's why it's critical for you to do that. Then we get into the motor. So pulse motor sensory, we've got the sensory, and now moving on to motor to help us distinguish nothing moves, weak movement, strong movements versus normal exam, and I'll come back and talk with this in a moment. And now we're talking about the motor. So complete, can't feel my rectum, all right? And then I mark down where does that become complete. And that can be where it starts becoming abnormal, and then past this point it's complete. Versus incomplete, something's getting through, I can feel something around my rectum, all right? So it's incomplete, but below the level of injury, none of my muscles are moving. What muscles am I testing? There's a zillion muscles in the body, but we're going to test critically 5 muscles in each arm, or 5 exertions in each arm, 5 exertions in each leg. So 20 total, and we're going to grade them. So I'm going to grade them by, let's go with, what do we do red? 5 is normal. 4 is weak. 3 is anti-gravity. 2 is really weak. 1 is barely moves, for lack of better terms, and 0 is paralyzed. So, what does that mean? Normal strength, nothing wrong. And when I check strength, if I am not getting a workout, I'm not doing it right. Because I'm trying to find any weakness. All right, now obviously, someone who's older, frail, little lady, I'm not going to super torque, but I'm going to find whether she has any weakness. A young person who's in the gym, you know, really bulked up, I may really have to torque on them to find any weakness. But I'm saying that's normal strength. 5 is normal strength. 3 is anti-gravity. That means, for example, my elbow, that means I can bring it full range of motion against gravity to bend my elbow the entire way. But the moment I put any resistance on it, I can't hold against resistance. All right, I just can't get it. And so 4 is anything between that. I can move it, I can provide some resistance. You can clearly overpower me, but I can provide you some resistance to get that 4. It's not normal, but I'm stronger than anti-gravity. 2 technically means I take gravity out of the equation, and now I can bend it full range, but the moment I add gravity, I can't get it full range. 1 is anything weaker than that, but is moving from a twitch to I can get it part way, but not all the way. And 0 is obviously paralyzed. The critical things are what's normal and what's not, and really in this gradation range. 3 to 5, that's the biggest thing to tell the surgeons, because if they're really down here, I mean, that's really bad. All right, and we're trying to figure out where does that weakness start? Is that weakness getting worse? Is it extending? It used to be only this far, so they used to be, you know, down to their grip. You know, they had some good strength, but now their grip is weaker, now their extension is weaker, stuff like that. So that's what we're trying to figure out. So, Mr. Nestor. All right, so now we're going to be ready to do the exam. Mr. Nestor, please come up. And again, as we do this, I'm going to do a shout out to Dr. Andrew Wright, an orthopedic surgeon, Lieutenant Commander in the Navy. I served with him last year in Iraq, and he had a great way that he shared about remembering this and teaching how people can remember it and use it, you know, under stress. So if you have to remember 57,000 muscles and exertions, you've got 5 key muscles in the arms and 5 key exertions in the legs. So, for the arms, you think about basketball, somebody passes you the ball, you have to catch it, elbow flexion. You get ready to shoot, wrist extension. You shoot, elbow extension. You scored, you make that fist. And you run down the court. I'm number 1, waving that finger. So, catching the ball, elbow flexion, C5. Getting the wrist into extension to get ready to shoot, C6. Shooting, elbow extension, C7. Making that fist, finger flexion, C8. Running down the court, waving your finger, interosseous muscles, T1. So when we do it, we're imagining he's on the spine board, locked in, he's got a servo collar on, he's got the sandbags, he's tied down. So I don't want to jerk his body as I do that, so if you flex your elbow, all your might, and again, if you're not getting a workout, you're not doing it right. So if I just grab him and go like this, look how I'm pulling him on the board. Not good. We don't want to cause further injury. So I always stabilize above my exertion, and you can see he's not moving. I'm not jerking his body, but I'm checking strength to that arm. So that's C5. Let's get that wrist back, getting ready to shoot. C6, right, stabilizing and pushing across. You shoot, elbow extends. C7, you score, make that fist. Finger flexion, C8. Spread your fingers. All right, I'm going to have you turn your hand this way. All right. If you'll notice, I'm coming right across the joint when I'm checking finger spread. If I go out here like this, Mr. Nestor, who's a super strong guy, why am I crushing his hand? Because I have torque advantage, I got all this power there. So you don't want to check out here, you want to check here. Another way is to basically go finger to finger. So I'm going to check against my finger. Stabilize and see. All right, that's strong. Well, I'm going to check against my other finger. So we'll do, put your hand that way. All right, so I'm checking against my finger. All right, so we're doing equivalent. We're not trying to overpower, we're trying to test true strength. All right, so small muscle versus small muscle. So C5, all right, wrist up, C6, elbow extend, grip, spread your fingers. And there we go. Those are the 5 exertions. Now we get to the low extremities. I'm kind of making this one up. So when I think about kicking the ball, so when I kick the ball, I'm going to be flexing my hip. I'm going to be extending, my knee. My foot's going to come up. My toe's going to come up, and then I'm going to land on my tippy toes. All right? So this one for hip flexion, it's L2. There's no real way to stabilize the body other than it's on the board and tied down, but have them bring their knee up. So bring your knee up. All right. Now I can really stabilize. So straighten out your knee. So that's L2, L3 with knee extension. Bend your foot upwards towards you, toes to your nose. L4, big toe. L5, step on the S. S1. All right. So hip flexion. Knee extension, foot up, big toe up, step on the gas. And those are the 5. Thank you, Mr. Nestor. Can you see it here? So, in writing those, all right, storing those, that helps the spinal specialist down the road know when the person's getting better, worse, staying the same, helps them make decisions, all right, about when they're doing surgery. And now that we're out, I can take this off and get back to breathing air. So C5, elbow, flex. C6, wrist, extend. C7, elbow, extend. C8, grip, finger flex. T1, finger spread. L2, hip flex. L3, knee extend. L4, ankle dorsiflex. The ankle doesn't extend it. Dorsiflex and plantar flex. L5, great toe extend. S1, ankle plantar flex. Alright, so those are the exertions you should be documenting. You can just write it. Remember, you're probably not in an emotional situation. Remember, okay, that elbow extension, was that C6? Is that C6? Elbow bends, elbow extends. Wrist up, grip, finger spread. Alright, I catch the ball, I get ready to shoot, I scored, I'm number 1. I'm kicking the ball, I'm flexing my hip, I'm extending my knee, my foot goes up, my big toe goes up, I land on my toes. And if you remember that, then you'll be able to just mark down on that scale of 0 to 5 what their strength level is in each of those, on the right and on the left, and it can be different from right to left, and it can be different in the sensory levels, all right? But that helps someone who gets the patient next to go, okay, this is what that person had, I'm re-examining him, I see that that spinal cord that was initially smacked in that injury is doing a little better, all right? So I'm seeing some recovery already. And based on that initial exam, you can give a lot of information. There was, I don't know, within the last decade, there was a football player who had a cervical spine injury in the middle of the game. He's conscious on the ground, laying on the field. The sideline doc comes up, does the exam and says, he's going to be fine, he's going to walk. Because based on the exam, he could tell certain things and say, this is a high probability of recovery. All right, we're going to do well. Because when we start scaling them, when we're in that trauma situation and we're in the ER and we're going, okay, this is an Asia A. Everybody wants to know, will I walk? Will I walk? Well, a few of the Asia A's, like less than 2% in a year, will walk. It may be easier to be in a wheelchair than have a reciprocating gait orthosis and a couple of lost strand crutches, hell of a lot of energy. Maybe it's easier to be in a wheelchair, but some of them will walk. We start getting down here, higher and higher percentages will walk, and that's what everybody wants to know. Will I walk? Will I walk? I've got this spinal cord injury. Will I walk? So it's not your job at the primary care level. We'll leave it to the spine surgeons to start talking that, those spinal experts. But you know, we want to give as much information, so also you get that information, the next doc gets the information, the surgeon gets the information and goes, yeah, I see you're recovering already, a bunch. That's a very good prognostic indicator then, hey, from the point of injury to now, I actually see that spinal cord is staying stable and I'm not seeing any change, and I'm looking at the images and I need to go in there and surgerize it and, you know, decompress that cord. There are also different types of spinal cord injuries. Everybody always thinks, it's easy to think, just meat cleaver, it's cut in two. Well, there's different kinds of spinal cord injuries. For example, you can have central cord syndrome, which is an injury in the neck where the arms are actually weaker than the legs. But the legs come off after the arms. Wouldn't the legs be weaker than the arms? The classic quadriplegia, tetraplegia scenario, where the arms have some strength, and as you go down, you get weaker and weaker. No, there's a central cord syndrome where the arms are actually weaker than the legs. There's a brown-sequard, which is a half of a spinal cord injury, so it affects one side. Well, the motor comes out on that same side, so the right leg is weak. But the sensory crisscrosses down at the end of the spinal cord, so the left leg is numb. So my right leg is weak or paralyzed, but I can't tell in three-dimensional space where my left leg is. Different kinds. There's an anterior cord syndrome. There's all these different syndromes that can happen with spinal cord injuries. All right, again, leave it to the spinal cord people to be putting that information together and explaining, you know, to our patient what's the probability of recovery, what type of injury, what to expect, the kind of rehab, things like that, which is where I get involved with spinal cord injuries in the rehab. And that's where we get into the E's. So spinal cord injury is defined by sensory motor. So is my sensation normal? Sharp versus dull, all the way to my rectum. Is my motor normal? All the way down to stepping on the gas. If all of that is normal, but I have a history of spinal cord injury, my injury recovered, I might just have some hyperreflexia, upper motor neuron syndrome, another lecture. But based on this criteria, my exam is normal. These 20 muscle exertions, my sensation is normal, but I have a history of it and I have some maybe residuals of it, but I'm better now. But we'll always classify you as a spinal cord injury because you had one. We just classify you now as an echo, an E for normal exam. All right, so you could start as a Charlie and end up as a Delta or Echo. You know, you could get better, and that's what we're looking for, just things get better. So The distinction of which of these are, that's not your job in the primary care. Out in the field, just document what you find. Somebody else will put a label on what you found and put a label on where the patient is at this time. All right, so in summary, it's important to get a good exam as far forward as possible to give later on information. When we were looking at a slide the other day from the trauma conference, had a gentleman fall from 8 feet of height, middle-aged, so he already had some underlying arthritis in his neck, fractured his face, orbital fracture, fractured his spine. Combined with the pre-existing arthritis, he had a bruise to his spine, and they said there he had a score of 75. Well, that's not useful to me. I want to know, where is that missing 25 points? Where are those things? And as they broke it out, then we started seeing that he had central cord syndrome, all right, with some weakness in the arms more than the legs, things like that. So that helps us look at it, and he ended up having surgery, anterior and posterior, because he wasn't making the progress the surgeon expected. And you may hear about steroid use. It comes and goes. You got to talk to the surgeon who you work for to know in your echelon of care whether they want you out in the primary care level, out of the A station, at the clinic, wherever, the urgent care, the ER you work in, whether that surgeon wants you to start steroids or not. And I just leave it like that, because that controversy comes and goes. At one time, if you didn't start steroids, the lawyers will write on you that was the standard of care. You screwed up, you killed this person, you paralyzed them because you never started steroids. Then they found it didn't really help. And you have infection risk and things like that. And it seems to come back in and out. So I just leave it. The people that are tracking it are the neurosurgeons and the spine surgeons. Whoever you work with, find out what they want you to do. And let them decide, because they have to then deal with whether they're doing surgery and spinal cord injury. And then myself in the rehab world, once they're stable enough, we're going to start working on their recovery and their adaptives, strategies and things like that. So catch the ball, you're ready to shoot the ball, you scored, I'm number one, you're flexing that hip as you kick the ball, you're extending that knee as you kick the ball, you're bringing your foot up and your big toe up, kick the ball, and then you land on your tippy toes when you come down. So remember that, sensory motor all the way down to the rectum, and you'll be good to go. Document what you got, and that helps the follow-on providers. Please subscribe. Hope you enjoy this. We're going to continue these series. All right, and out here.